So we're not going to talk about resuscitation at this point. I get the opportunity to do that later. I'm going to talk about something that we've been playing with for the last couple of years, the trauma hybrid OR, and then we'll throw in a little lagniappe for those of you all from Louisiana, where I went to college, on aortic occlusion catheters, put it in the ED. I have no conflicts. So I am in Houston right now. I like to tell people that I have 2 level 1 trauma centers in Houston. This is our place, the white building, and then the Ben Taub is there, and those of you all have heard me say this before, we're appropriately right across the street from the zoo. So paradigm changes. You know, what are the paradigm changes that have happened? This is in my surgical career, which, you know, is getting longer and longer every day. Laparoscopic surgery came in when I was a chief resident. So there was no laparoscopic surgery in our hospital. We did the first lap appy with the rigid bronch instruments, took 3 hours. Did the first lap chole, which probably took 10 hours. And, you know, not just a couple years later, those cases were down, in many cases, to 10 minutes and 30 minutes. So a real paradigm shift in just 2 years, starting in the early 90s. 2 or 3 years later, 75% of my cases were laparoscopic. Ultrasound. You know, I broke, as a resident, broke down the door to the radiologist's office at 2 a.m., stole their ultrasound, and used it to ultrasound the right quadrant of a patient. Now ultrasounds are everywhere. People have them in their pockets. So a real change in how surgeons use ultrasounds in 25 years. IR techniques, for those of you all who lived through this, with IR cardiology and vascular, fighting over cases and who was going to do what. That's kind of settled out a little bit, but it wasn't all that long ago where IR just wasn't really around in the acute management of surgical patients, and especially with percutaneous drainage of abscesses, etc. Robotic surgery, you know, certainly wasn't thought about a decade ago, except in a couple people were thinking about it and doing it up in DARPA, and now there's, you know, billboards in every city in the United States talking about robotic surgery. Damage control surgery has been around for a long, long time, but really came to the forefront based upon 22 cases in a paper published in Journal of Trauma in 1993. And that's where a modern evolution of damage control surgery comes from. And of course, resuscitation, you've heard some talks already by Sandro and others yesterday, and we'll talk a little bit more this afternoon. That pendulum swings back and forth a lot, but big changes in that. So kind of what's next? You know, what is next? What's going to happen? There's one thing true about surgery. It's not static. It doesn't stand still. The group that's here and around the country that does acute care surgery or trauma surgery, emergency surgery, whatever, is fairly inventive. You know, we like to invent things. And if somebody's got something that we can't have, you'll break down the door and go get it at 2 a.m., right? So what's next? I'm going to talk about time throughout here, and time's been mentioned already. Time in our world, the reason you're here, is extraordinarily important. Death happens very, very quickly, so if you're going to help decrease death rate, whatever you're going to do has to be done very early. That steep part of the curve there with the red thing around it, you know, 50% of the deaths occur within 2.6 hours of admission. 50% of hemorrhagic deaths occur within 2.6 hours of admission. You can't be making stuff up at 2 o'clock in the morning. You have to have it in place and ready to go. So the focus on damage control surgery now, damage control surgery is really on really rapid hemorrhage control, and in 2013 often includes angiography. Mike Rotondo's paper in 1993 did not mention interventional radiology, and many of the subsequent papers on damage control surgery don't either, but now it's really part and parcel of what we do. Okay, now if you look at what we do when we go to stop bleeding, such pre-hospital, you can use external compression, there's dressings, manual compression. You know, the hand is a really good thing. The finger is the best instrument God gave us, works really well. Tourniquets of different varieties, pre-hospital. The knife is a great way to help control bleeding, and a clamp, or your fingers again. Suture and fingers, truncal tourniquets are out there for non-compressible or thoracic, abdominal, and pelvic bleeding. And then intravascular with all of the blood products and adjuncts that are coming down the pike, and we won't talk about that right now. Those are all pretty fast. If you really prepare ahead of time, you can do those things quickly. If you don't have prepared ahead of time, and it takes you 60 minutes to get something into the patient, whether it's a knife, an IR thing, a suture, a product, then you're going to miss half the bleeding to death patients, right? So if you have your goal has to be within minutes there. And then balloons and embolizations, slow. So if you have IR capability in the middle of the night, you have your in-house IR person at your hospital, that's really unusual. Most people around the world don't have that. We don't in our hospital. We use them a lot. They have to come in at night. During the day, during the week, it's very quick. We can have people up in IR within 20 or 30 minutes. and getting balloons in. So time's important, stopping bleeding's important, high death rate with multiple serious injuries. This slide I put together, and I talk to our residents about this all the time. For those of you all who are trained residents, you sit there with them in the ED and you look at them in the eye and you say, what are you going to do now, right? What are you going to do? That's kind of the sine qua non question for residents. And you're sitting there in the ED with a really sick patient, especially one who's got multi-system injury, head, hemorrhage, etc. And you kind of go, okay, we've done the initial chest x-ray, fast exam, pelvic film, you got lines in, you got blood going, whatever you've got that initial 10 minutes done. Then you got to decide where to go. If you go to the operating room, which is a great place to go, most places you can't angio and you can't CAT scan there, right? So in the places where you like to angiogram, pelvic bleeders, etc., and you can't CAT scan the head to see if they have an epidural or subdural that needs an operation, but you can do lots of other things there. It's a good place to go. Angio, if you decide to go with the angiogram suite with that really sick patient, you can't operate, you can't CAT scan in most places, or they say you can't, but in fact you really can, they just don't tell you. But you certainly can't resuscitate well and not frequently very cold. And then if you go to CAT scan, you really can't do anything but image. Image is really important. It really drives a lot of things we do, and we do it almost on every really sick trauma patient at some point. But where do you go with that really sick patient, right? And if you make the wrong decision, has anybody been there before? You get that sinking feeling in the pit of your stomach and you say, I wish I wasn't here. I wish I was someplace else. I wish the patient was someplace else. So if you make that wrong decision, people have written about this, they die. Because you had delay to whatever that place is you wish you were, right? And equals death. So I'll just run through this patient real quickly. This is a patient who jumped off the overpass, fell 25 feet. You can see the physiology there on the right-hand side, significantly tachycardic, not a little bit, but a lot. The dying heart rate above 120. Blood pressure is low. Hemoglobin in this 25-year-old lady is low. That's a bad sign. Base deficit, really low. We use TAG, so the ACT, the plasma component of this, was out significantly. The MA is really low, fibrinogen and platelets required, and then the LY30 was above 3%, so it needs TXA. This patient's in a world of hurt, has a really high mortality, but the fast exam was negative, negative, negative. I don't trust negative fast exams, so I made a little incision in the abdomen there and make sure there was no blood in the abdomen. There was none. Chest x-ray was okay. She needs pelvic angiography, pelvic packing, and you can go do all that. But where are you going to go with this patient? CAT scan, OR, or IR, right? Difficult patient to take care of. We'll come back to that in a minute. The Eastern Association for the Surgery of Trauma guidelines, and we're going to hear about pelvic fractures later today, but they recommend in really sick patients as you get to IR and do pelvic angiography for really sick hemodynamically unstable patients. So Blau and his group have written about this from down in New Zealand and Australia. In this kind of patient I just presented, the mortality is 30%. It's a really high mortality when you look at a group of patients. It's not very few disease processes in trauma or in medicine have a published mortality of 30%. Diane Schwartz is one of our fellows a couple years ago, put this paper together. It's accepted the Journal of Trauma, will come up very soon, and talked about this adjusted mortality, about mortality. During the day, during the week, it's lower with pelvic fractures, and at night on the weekends, it's higher related to time to stopping bleeding. So we got to think about how we're going to weave all this together, right? We have these modern trauma centers, or frankly, if you sit back and look at it, set up for penetrating trauma patients. Guy's got a hole in his abdominal chest, he's hypotensive, taking him to the operating room, fill up the hole, stop the bleeding. But for the blunt trauma patients, which is the majority of what most people see, who have head injuries, pelvic fractures, long bone fractures, and then abdominal chest bleeding, we're not really set up well for that because you'd like to be able to CT, angio, and operate on all of them, all in one place. Don't you guys love the road trip? The 2 a.m. road trip, where you wander around the hospital with the sickest patient in the whole world, and you got to go to all these little different silos of care. Lines fall out, tubes fall out, and the literature would suggest that death rate is increased when you go on the road trip. And they're really bad when you go backwards, right? You go to CAT scan for something, go to the OR, and then you go CAT scan again. I hate that. And the patients don't do well. They don't do well. And you start doing this, you go, why are we doing this? This is stupid. Who designed this system to allow us to wander around the hospital? If you go back 30 years, we didn't do that, right? Because you didn't do IR. The CAT scans weren't very good. You just went to the operating room and operated. And you layer on all this technology now, and you make us go to all these different places. Nobody would design the system that way, but that's what we do. So how do we change it? How do we change it? So we go through that thought process, you go through the published literature, we've all been on the road trips. I want to go to one spot. That's what I want to do. I want to go back to one spot. I want to go to an operating room that has all of that capability, and rather than taking the patient to the silos, the specialist silos, I want those specialists to come to the patient. Right? It's very patient-centric. It's a nice buzzword, it's really true. We should all be patient-centric. All those specialists, the IR guys, the vascular guy, the CAT scan guy, everybody comes to the patient. Do all your stuff in one area and then go to the ICU, right? No more road trip. Anybody for that? There you go. All right, not a new idea. Not a new idea, okay? Everybody, anytime you think you got a good idea, you go read the literature and somebody's already done it before and they've done it over and over and over and published much papers. To include this idea of this balloon thing, we kind of like this balloon idea. I'm going to weave this story together. Hopefully I'll finish on time. So the 21 balloons published by Shafton's group over several decades ago, 21 balloons put in the ED for people who had exsanguinating hemorrhage. We thought we had a good idea in 2011, so we went down to the cadaver lab, 2 cadavers, put these balloons in. Now we're training our residents and fellows on a quarterly basis how to do intra-aortic balloon placement in the emergency department. We did this again last month. And our indications for this balloon catheter are really physiology. So chest x-ray is normal, we get that digital x-ray pretty quickly, fast exam's okay, so non-thoracic bleeding, big physiology abnormalities, intra-abdominal extremity bleeding, patient's about to arrest. What we do now is put this balloon in the ED. We haven't done an ED thoracotomy for non-thoracic bleeding in almost a year at our center. We're very happy with this. It's been quickly adopted by our group. They really like it a lot. It's a small, portable, cheap kit. We have a hemorrhage control drawer in the ED. It's got tourniquets, combat gauze, and this kit in it. It costs $418. What's nice about the kit as well is because there's not a lot of IR techs in the ED at 2 a.m., that the packing list on here is in the order of insertion, so they can hand the stuff to you. We published a case series of this with 6 or 7 cases. And you know, these people are really, really sick. Their pressures are 60 and 70. One patient had arrested. It's pretty fast. We've got together a group of people from around the country. This paper is accepted in the Journal of Trauma, talking about these 2 concepts. And if you notice the last authors on there, the leadership of the American College of Surgeons, so in the AAST. So we have this idea is starting to take hold a little bit. How we're actually going to implement this, I'm not exactly sure. But let's talk about this case now. Guy's pressure 60. He's tachycardic again. We started our 1-to-1-to-1 with the thawed plasma in the ED and the platelets fast as negative again, over and over and over. Be careful of a negative fast. Lactate and base deficit LY30. So kind of similar to that last patient. Wide diastasis there. He's a non-responder to blood products. So there's the aortic balloon catheter going in the ED. The medical student's hands are holding the pelvis together. Why we do that? You can't put a pelvic binder on and put this aortic thing in at the same time. There's the balloon up. If you guys can see the balloon here, that's the intra-aortic balloon. You know, the nurses thought he was going to die, put the paddles on as well. Right, and the intra-aortic balloon going in, but he did not arrest. And balloon's up and binder now is in place. You will relieve the medical student of external compression. Binder's in place. That's his picture. That's the aftermath. It really was put in the ED. And the IR guys weren't quite ready, so we went and CAT scanned him looking for his head and all the other things, and that's the balloon in the abdominal aorta, just at the diaphragm, about 3 centimeters or so from where you would put a clamp on the aorta if you were opening the chest. So we went to the OR, we packed, we IR'd, embolized, removed the catheter, fixed the femoral artery. It's an open repair, and the guy ended up dying from his head injury, had a horrible head injury. All right. So these patients that we've put these in now, we've done now 14 or so, have not died from hemorrhage. No more bleeding to death from hemorrhage. They do have serious other associated injuries, so there is a high death rate in these guys, but no ED thoracotomies for below the diaphragm bleeding in over a year. Now, the technology, we start wrapping up. This is Robotic Arms and the Tesla car. They've all been catching fire lately, unfortunately, but these robotic arms are making everything. They're making everything, and they're really, really pretty interesting. I'm going to see if this will... Can you punch the things? Will it work? Let's see if it'll work. Can you guys do that back there? Just double click on the black box. Yeah, about half the time it works and half the time it doesn't. It's not working. That's okay, we'll keep going. That one doesn't work either. So we're not really, this is not pie in the sky stuff. I was on call last Sunday. We're in a hybrid OR in our Heart and Vascular Institute, which is a road trip away. We're not set up quite right yet, but the guy's got a torn aorta. IR came and did the embolization of bad pelvic fracture. We stayed out of that pelvis area and looked at the bladder and bowel. Had an extraperitoneal bladder injury, free fluid in the abdomen, but no intraperitoneal component. And then ortho X-fixed the pelvis and X-fixed the tibia, all in a hybrid operating room. So we went to one spot. Now, it's all on the other side of the building, not in our trauma OR area, but the concept is there, and we're starting to work on it. These hybrid ORs are pretty interesting. They're all over the place. There's multiple vendors that make these things. What's nice about it is it can come around to a CAT scan. You can image the whole body. And then at the push of a button, because this thing's highly mobile and can turn in 50 different directions, it goes out of the way. It gets out of the way at a push of a button. So if you need to have all your interventional radiology, laparoscopic, all that kind of stuff, and you punch a couple buttons, that stuff moves away. You take out your knife, you make a big hole, and put a clamp on with your hands. And then, by the way, you can do a good CAT scan. So if you're in IR and your IR guy said you can't CAT scan there, that's really not true. All those things will do pretty good CAT scans. Your head, a trauma CAT scan. Maybe not if you're going to do microvascular aneurysm stuff, but if you need to see if the guy's got blood in his head that needs an operation, those hybrid ORs are good enough for that. So the paradigm shifts are out there. Just in the last 25 years, we've changed. Think about how much trauma surgery and surgery in general has changed. I think these new things are coming down the pike. They make sense from a physiology point of view. They make sense from a road trip point of view. Here's that little chart again. In that decision process, I want to go to one spot. And instead of wandering around, I'm going to go to the operating room where you can IR, OR, and image with all of the different things that we have. Now, lots of questions. Is this going to be relegated? The balloon catheters, for instance, why can't that be put in by ER guys in community hospitals? There's a lot of people that bleed to death out there, and they come in with a balloon catheter up. That's kind of a crazy idea, but I think that's probably going to happen. Hybrid ORs are expensive, no question about it. But I think they'll allow us to bring patients to one spot, avoid the road trip, bring specialists to the patients. And of course, we're going to track all this and see if we improve patient outcomes, or is this just another expensive toy? They'll be looked at, studied, and then put back on the shelf. Who knows? We're on the way to building our trauma hybrid OR. Other institutions are doing the same. I think this is the evolution of acute care surgery, damage control surgery, trauma surgery, whatever you want to call it. My guess is the young folks in the audience will be doing these procedures routinely, just like we now do laparoscopic surgery routinely, thinking about all the discussions that were had back in the early 90s. And it's exciting to change and integrate these technology for the benefit of the patients. Thank you very much.